A very good morning. At the outset, I would like to thank AIOS and the scientific committee for accepting our IC and giving us this opportunity to present our area of interest, which is MIGS. Initially, I would introduce MIGS and the procedures that are available, and then I would talk about trabecular meshwork cleavage procedures like KDB goniotomy and GAT. And my co-instructors, Dr. Sunita will talk about trabectome, and Dr. Siddharth will talk about eye stent and Zen implant. Though conventional filtering surgeries like trabeculectomy and glaucoma drainage devices give an effective intraocular pressure reduction, their unfavorable safety profile and bleb-related complications such as scarring, bleb leak, blebitis, bleb-related endophthalmitis, and implants such as implant block or implant extrusion is a concern. How to avoid these complications? So minimally invasive glaucoma surgeries were described way back in 2012, which are approached by an ab interno approach. They cause minimal trauma to the target tissue, faster operating time, they have modest efficacy, high safety profile, and a rapid recovery with minimal detrimental impact and quality of life. The American Glaucoma Society has this classification where MIGS surgeries can be classified as non-bleb forming and bleb forming. In the non-bleb forming, we have this inflow reduction, which is mainly the cyclophotocoagulation. And the outflow enhancing procedures are trabecular meshwork or canal-based surgeries, which are again, like I already talked about, excising the trabecular meshwork or causing cleavage, which are like trabectome, the GAT procedure, and the Cahook dual blade. And the implants are the eye stent and inject and hydrous implants. And the bleb forming ab interno procedure is the Zen subconjunctival implant. So with this introduction, I'll take you towards the most important prerequisite for doing all this MIGS procedures, that is the intraoperative goniotomy, and we'll talk about the few tips and tricks about intraop gonioscopy. See, I will take you about pre-op and the extraocular modifications that we want to do. So step one is office-based gonioscopy. Why is this important? To understand the angle and for surgical planning. And the resource that is available at gonioscopy.org is immense. You can go through all the different angle structures and the different angle presentations that are available there, and then practice in the office or the clinic, and then have an idea before actually taking up the patient for the surgery. About angle anatomy, it's very important to identify the scleral spur, which is the surgical landmark that separates anteriorly for the canal-based surgeries via the trap meshwork, and the posteriorly for suprachoroidal-based surgery via the ciliary body phase. Step 3 is about anesthesia. It can be done under topical anesthesia, but the problems of involuntary eye movements has to be faced. And with peri or retrobulbar block, you get the echinacea. And for novice surgeons and beginners, it's not unreasonable to begin with a block. Why? Because it builds your surgical confidence and avoids potential intraocular complications. Very important adjustments about the head and the microscope rotation for most of the MIGS procedures. It's advisable to approach the temporal approach to reach the nasal angle, and then rotate the head 30 to 40 degrees away from the surgeon, and rotate the microscope temporarily the same degrees towards the surgeon. And at the end point, align the microscope oculars coaxially, increase magnification of the angle once you get view of the angle structures, and then increase the light intensity to view the structures. So here is a video which shows you the adjustment of the microscope. So this is a Zeiss Lumera microscope where you get this adjustment knob on this side, and you can tilt it at around 35 to 40 degrees. And in this microscope, we have a place to keep a mobile phone where what I use in iOS application, the measure application, and it gives you almost accurate reading for getting that angle of 45 degrees. So this is the app and this is a descriptive picture where I am showing the mobile kept on the laptop and getting that 45-degree angle. And for surgeons who do mixed procedures on a regular basis, you might not have to adjust it every time when you operate. So you can actually mark it on the microscope and then align these marking points every time you do the surgery, so that you don't have to keep adjusting it every time you take up the patient for surgery. And as compared to normal phacoemulsification, in MIGS procedure, there is an increased working distance between the oculus and the surgical field. Like in this image, you can see the left-hand side, the A image is of phacoemulsification, whereas the B image is of doing a MIGS procedure, where the surgeon is sitting temporal, but since the eye is rotated away from the surgeon and the microscope is rotated towards the surgeon, you get a increased distance of working. And while doing phacoemulsification, you have full access to the entire cornea. You have everything visible. Whereas in the angle surgeries, the viewing space is confined to the anterior chamber depth and the area of interest, the trabecular meshwork space. About the step 5, which is again gonioscopy lens selection. All the surgical gonio lenses are modifications of the Swan-Jacob lens. They vary in the degree of corneal contact, the field of view, magnification, and the handle length. The handle comes contiguous with the gonio lens. Exception is this Vogue TVG lens, where the lens is a free-floating lens and it originates from separate handle. The fixation ring is for the globe stability, and the lens can rotate in X and Z axis. So these are the descriptive images, no financial interest. So the TVG lens is the one which is shown above, where you have again the image is shown on the left below also, where there's a ring to fix the lens onto the globe with the sharper tips, and then you have a free floating lens through which you can view the angle structures. And then Glaucos comes with disposable surgical gonio lenses, and this is an autoclavable lens from Ocular. Step 6, the hand positioning. Hold the lens with the non-dominant hand and place and rest the palm on the forehead or cheek based upon the laterality of the surgery. Then arch the fingers over the nasal bridge. Unlike though it's a bimanual procedure, the MIGS procedures, phacoemulsification is a bimanual intraocular surgery, but in the angle procedures, one hand is extraocular and you have to do intraocular and extraocular simultaneous manipulation. So this is like how the left image on the A image is being done on the right eye, where the hand is the right dominant surgeon, the left hand is just resting over the forehead, and for the left eye, the left non-dominant hand is resting over the malar prominences. Intraoperatively, what are the steps or the tricks to identify the trab meshwork? Based on the pigmentation in like pigment dispersion syndrome or pseudoexfoliation glaucoma, moderate to heavy pigmentation provides a natural visual guide. And there are other techniques like staining with trypan blue, which in less than 60 seconds, it's non-toxic, diffusely stains the trabecular meshwork. And also by reflux of blood into the Schlemm's canal, or by causing hypotony, you can do a provocative gonioscopy and force the blood into the Schlemm's canal and have a view of the angle. So with this background about intraoperative gonioscopy, I'll take you through the two procedures. First, I will talk about gonioscopy-assisted transluminal trabeculotomy, or GATT procedure, no financial disclosures. It was introduced and developed by Dr. Grover et al. At the Glaucoma Associates of Texas. It's a non-bleb forming MIGS procedure, conjunctiva sparing, ab interno, 360-degree trabeculotomy. About the patient selection planning, in the initial days, when we need a cooperative patient, and if you are doing under retrobulbar or peribulbar block, then it's okay. About the indications of the GAT procedure, to start with primary and secondary open angle glaucoma, you can do it either standalone or with cataract extraction. Initially, to take about patients who are controlled intraocular pressure on more than 2 medications, where the aim is to decrease the number of medications. Mild to moderate glaucoma would be better to start with, but even severe disease of glaucoma is also treatable with GAT procedure. And preoperative gonioscopy, as we discussed, is an absolute must before taking up the patient. And we can practice few sessions of intra-op gonio at the end of a regular cataract surgery to get accustomed to the gonioscopy. When doing in combination with cataract extraction, a detailed consent about cataract surgery and the MIGS procedure has to be explained, and discuss the recovery delay as compared to a cataract extraction alone, and discuss the head positioning that might be needed post-operatively to decrease the hyphema, and also about the intraoperative head positioning, which is unlike cataract surgery where we have to tilt the head and all that. And which to be done first, I will just go to the next slide. And when done standalone as a GAT alone, preoperatively you can use pilocarpine to constrict the pupil and then enhance the visualization of the angle. So this publication by Cahook et al., which looked at which to be done, either cataract surgery to be done first or about MIGS procedure to be done first when done as a combined procedure. They saw that there appears to be no significant angle visualization difference whether the surgeon chooses to complete angle surgery before or after phacoemulsification. As discussed about the optimum head position before itself, 45 degrees, the microscope is tilted towards you and the head is tilted away from you. This is a comparison between all the instruments that you use in a case of trabeculectomy as compared to the instruments that are needed for GAT procedure. See the decrease in the clutter that we have, with no disrespect to the surgeons who operate trabeculectomy. And about gonioscopy, I had already discussed. 2-3 points. Don't use the lens to direct the eye. When you use the lens to direct the eye, you apply pressure over the cornea, which can, distort the visualization of the angle. And once you get the correct anatomical location and then the angle visualization, zoom in to see the desired area. And this is how the intraop visualization of the nasal angle appears. And then about wound construction, few tips is to avoid the limbal vasculature so that no bleeding happens over the surface, because when the blood mixes with the viscoelastic that you place over the surface, it just makes the field of surgical vision very messy, and then it's you don't get the clear visualization. And when done with cataract surgery, 2.8 to 3.2 millimeter incision is more than enough. When done as a standalone procedure, even people do with 15-degree blade or a MVR, which is less than 2 millimeter incision to do a GAT procedure. A temporal incision is preferred. And when I say this tangential incision for suture entry, I'll show you in the next video how it actually helps. And intracameral pilocarpine in standalone procedures would help you prevent any trauma to the phakic lens, and then also improves the visualization of the angle. And suture and the forceps that we use to hold the suture intraocular and pass the suture along the trap meshwork, it's better to place it in the anterior chamber before putting the lens, because once you put the lens, the external and the internal appearance of the suture is different. I'll show you that. And then when reflex heme is noted, keep the eye firm with putting viscoelastic. And at the end of the surgery, half fill anterior chamber with viscoelastic or air tamponade is advised to decrease the hyphema, because we are doing a 360-degree procedure, ripping the trabecular meshwork. There are good amount of chances of post-op hyphema. How to know if there is a false passage? So when false passage happens, you see most of the time it goes into the sulcus, and then you see a lot of undulating movements over the iris surface. And if you keep on passing the suture and it has gone, and usually after 20 to 30 strokes of passing the suture along the trap meshwork, it usually comes out, travels the 360 degree and comes out. But you have keeping on doing and it's not coming out, then when you pull it out, it will not come out in a circumferential way how it is supposed to come. It will just come out like it has gone through a keyhole and come out straight. So I'll again show you that. And if resistance is felt, so that means how we can identify that? When you're passing the suture, rather than the suture moving smoothly, it will push the globe along. Then you will know that it is not going freely. You are feeling resistance. So what to do at that time? You can take the suture out and you can go in the reverse direction. Rather than going in the clockwise direction, you can go in the anti-clockwise direction. Yeah, so this is the surgical video. Let's go step by step into that. So after, sorry. So after the initial adjustments are made, so this is the incision that I'm placing tangential. So if this tangential entry would help the suture to go to the nasal angle, will help us go to the nasal angle. When we make the temporal incision, it is easier to hold the suture and just pass. Just imagine doing a horizontal incision and where the suture is just lying in the pupillary axis. Now taking this suture all the way to the angle, in the nasal angle, and then passing, the suture will coil around. Since we are using a 5-0 proline suture which has a good memory, it will coil around and it won't go that easily. This is a temporal clear corneal keratome incision. You just see, this were my initial cases where I had, didn't avoid the limbal vessels, and it's kind of bleeding. So this blood, when mixes with the viscoelastic that is placed on the cornea, it kind of messes up the visualization. So this is the initial goniotomy incision that we make with the MVR blade. So again, this is what I told after about the placing the suture inside. See, extraocularly the suture is here, whereas intraocularly the suture is here. So if you place the lens first and then you want to introduce the suture, the lens covers your side port. Through that suture, through that opening, you will not be able to, keeping on, you will be kind of causing actually DMDs. So better is to place the suture inside, take your MVR also inside and keep it, in the area of interest, and then place the angle, gonio lens, get a visualization of the angle, and then cause your initial goniotomy incision. So introducing the forceps, what I use is Alcon's Grieshaber forceps 23 gauge, and then hold the proline suture, and then you see the tip has traveled 360 degree and it has come out. And again, you see how circumferentially the suture is coming out. It is traveling in the circumferential manner and it's coming out. So this is a very obviously the suture has gone and come out. That's an indication. But this is again an indication to tell that the suture has gone circumferentially. When it doesn't go and it goes into a false passage, when you, after 20-30 strokes, you anticipate that it has gone into a false passage and you take it out, it does not come in that circumferential way. It just comes directly the way it has gone inside and it's coming out. This is another case where I had done a surgery in a post-VR case where the conjunctiva, subconjunctival oil bubbles were there, and we had done a 360-degree goniotomy. So this is a nice cleavage cleft that is formed in the trabecular meshwork. You see, this is the superior angle, this is again the nasal angle, and then this is the temporal angle. So the patient is doing very well with just one medication, timolol, who was uncontrolled IOP with 4 medications, moderate glaucoma post-VR surgery, and at 6 months post-op, his pressure is maintained at 12, 14 with just timolol. Post-op follow-up, hyphema is expected, just like as I told, and what we advise is head end elevation. Initial post-op day, since we are retaining viscoelastic in the anterior chamber with some amount of inflammation, hyphema, IOP may be high, you can give Dimox for the initial 3 to 5 days. Depending on the severity of glaucoma, AGMs has to be continued. So most of these mixed procedures, as I initially told, have modest intraocular pressure control. So these are not gonna give you completely drug-free patient. So you might have to put the patient on 1 or 2 medications depending on the severity of glaucoma. And if the patient had been a steroid-induced glaucoma kind of a patient, at 1 week post-op, depending on the intraocular pressure and the steroid response and the inflammation, what we have seen and what we have noted is we switch over to NSAIDs. We don't continue the patient on prednisolone for a longer time. Or if inflammation has reduced, then we can actually switch over to softer steroids like loteprednol. Post-operatively, role of pilocarpine, yes, you are creating 2 raw surfaces by cleaving the trabecular meshwork, and the area that is done is more in a GAT procedure. You are creating a 360-degree raw surface. So pilocarpine does have a role in constricting the pupil and preventing pus formation as compared to a KDB procedure where you are doing a limited goniotomy. Advantages of this procedure, it achieves a 360-degree trabeculotomy and it's a conjunctiva sparing procedure. It's cost effective as compared to KDB. The learning curve is steep, but it is short. That's all I have about GAT. Since our second speaker could not come because of personal reasons, I would talk about Kahook dual blade surgery also. Developed by New World Medical, Kahook dual blade is a instrument which has a sharper tip, and then it has a ramp, and it has dual blade. So used for MIGS procedure to do a trabeculectomy, trabecular meshwork cleavage procedure. The indications are same like any of the MIGS procedure that we do, mostly to start with POAG patients or JOAG and other forms of secondary open angle glaucoma, and we can also even do in congenital glaucoma. Contraindications, closed angles, where it is closed by synechial formation. In occludable angles, after doing a PI, if the angle opens up, still you can do these MIGS procedures. Relative contraindications are patients on anticoagulant medications and bleeding disorders. This is an animation video which shows how this Kahook dual blade works. So after making all the incisions, like the temporal incision for introduction of the blade and putting the viscoelastic and getting a visualization of the angle, the blade is introduced. The sharp tip easily penetrates the trabecular meshwork, and then the ramp lifts up the trabecular meshwork, and the dual blade causes cleaving of the trabecular meshwork. So this is a combined phaco-KDB. After doing the cataract surgery, the anterior chamber is filled with adequate viscoelastic, and the microscope adjustment is done. And after placing the surgical gonio lens, you get the visualization of the angle. Now with the introduction of the device, so there are 3 kinds of techniques that are described. This is what is the meet and greet technique, where which most of us follow. So the first 2 to 3 clock hours is done, and then you go back and then do the another 2 to 3 clock hours and meet the initial incision. And then this trabecular meshwork remnant is taken out by a forceps, and then the viscoelastic is washed out. A limited hyphema is seen as compared to a GAT procedure because the angle cleavage that is done is limited up to around 120 degrees as compared to 360 degrees in GAT procedure. Post-operatively, here we can see the cleavage cleft, and almost 75 to 80% of patients have some amount of hyphema, but it all reduces by 2 to 3 weeks of time. This is our original article published in IGO about our initial experience with phacogoniotomy using the Kahook dual blade. It was a pilot study about with 9 patients, then where we had seen a reduction of around 25 to 30% reduction in the intraocular pressure, and the mean reduction of AGM was about 2 AGMs were reduced from the patient's AGM profile. About the contraindications, any allergy to anti-glaucoma medications, like every time what we reiterate is that this achieves moderate amount of intraocular pressure control. So you would have to put the patient back on medications. So if the patient is allergic to anti-glaucoma medications, then better not go for MIGS procedure, go for trabeculectomy. A very high intraocular pressure or a very low target intraocular pressure is if it is needed for the patient. And then like angle closure and if there are any new vessels in the angle. Limitations, the cost and the learning curve. So to end with, I would like to just have this picture, like how much IOP is decreased. At present, what we achieve is at around 25 to 30% of intraocular pressure reduction. How long? It's too early to say. With 6 months to 12 months of follow-up, we have seen patients maintaining that intraocular pressure reduction. The cost, obviously GAT procedure is minimal cost, only the cost of the 5-0-proline, the surgical gonio lens is autoclavable, the suture, the forceps is autoclavable. Is it available to us? KDB is not available at present. Easy to learn? Yes, with regular practice, it is doable. Thank you.
KDB, I just talked to him. It's available now. They have got the import license.
Okay, okay.
So
okay.
I think soon it will be available.
Okay, that's good. Next, I would like to invite Dr. Sunita to give her talk. Questions can be taken at the end of all the sessions. Thank you.
So at the outset, I would like to thank Dr. Mahesh for giving me this opportunity. I'll be talking on ab internogoniectomy with trabectome. So if you look at this glaucoma management spectrum, MIGS were designed to bridge the gap between medical and laser therapies and more invasive filtering surgeries in mild to moderate glaucoma, especially when the patient is undergoing cataract surgery or when the patient has developed allergy or is non-compliant to the treatment. So MIGS can be classified based on their physiological mechanisms and anatomical site of action. And in India, we have been doing the procedures, the Schlemm's canal and trabecular bypass procedures and various types of trabeculotomies. And the mechanism of action is to target the site of maximum resistance and thereby increasing the outflow through the conventional pathway. So TM and inner wall of Schlemm's canal at the site of maximal resistance, and the maximum concentration of the collector channels are present nasally, and it's better to target this area. So I'll be mainly talking about trabectome, which was approved in 2006, and it's a stand-alone device, and it utilizes a controlled plasma-mediated ablation system and achieves complete removal of the diseased trabecular meshwork and inner wall of Schlemm's canal. Since it's a excisional goniectomy, it minimizes the chances of scarring and reocclusion of the collector channels, as the remaining edges of the TM are far apart, as you can see here. And it incorporates, the biggest advantage is that it is associated with the irrigation aspiration system, and that definitely helps in the initial stages to increase intraoperative visibility as it pressurizes the chamber and maintains the anterior chamber and also manages the blood reflex. The foot plate, which is there, it helps guide the electrosurgical tip and also protects the adjacent tissue, so the collateral damage can be prevented. It can be there as a probe which can be attached to the phaco, so phaco compatibility is also there. So it can be used in all types of glaucomas, even in narrow angle glaucomas after a patent PI, and even in congenital glaucoma. And Dr. Mahesh has already discussed about the position and setup of the patient for any goniotomy procedure. This is the animation video wherein a 1.8 millimeter clear corneal incision is made, and the viscoelastic is placed over the cornea. It's very important to verify the angle view before starting the procedure. And this is the probe with the tip, insulated tip. The irrigation is coming from the side and aspiration at the tip. And this is the active electrode for the ablation and insulated foot plate. So once you introduce the probe inside, you engage the trabecular meshwork and then start ablating in one direction along the arc of the Schlemm's canal, and then rotate the handpiece and ablate in the opposite direction. So as has already been mentioned, it will go very smoothly if you are in the right plane, and you will not feel any resistance, and then the irrigation and aspiration. So as with other mixed procedure, it is always good to combine the procedures with the phaco. And again, the procedure is performed before phacoemulsification. Identification of the angle is done, and then the incision is given, and with the probe, visualize the trabecular meshwork and then engage it and just rotate it and ablate the TM and inner wall of Schlemm's canal in one direction, and then reverse the tip and do it in the other direction. And as you keep rotating the gonio prism, as you can see here, you can target almost 160 degrees of the angle. And here, after completion of trabectome procedure, you proceed with the phacoemulsification. And in all these procedures, if you see this fluid wave at the end of the procedure, when you form the anterior chamber, you see this blanching of the blood vessels, and this ensures that you have made a good connection between the anterior chamber and the collector channels. So this is to ensure. So there are various studies which have shown the efficacy of trabectome, and this was the first analysis wherein almost 5,000 trabectome surgeries were analyzed for a period of 90 months, and they assessed the survivability of patients resulting in IOP less than 21 millimeter mercury, and at least 20% reduction in the baseline IOP and no additional glaucoma surgeries. And the results were that it was the survival analysis was done, and 66% success was achieved in trabectome alone and 85% in phacotrabectome. And it was concluded that it lowers the IOP by approximately 36% while decreasing the number of medications by less than 1. Trabectome also works after failed trabeculectomy because collector channels do not atrophy completely. So one can also do trabectome or any angle procedure even after failed trabeculectomy or implants. So I'll just in short about our data. We did, it's going to be published in IGO. So we did 58 patients and we followed them up to 1 year, and all types of glaucomas were included, including congenital glaucoma. So I also included about 35% of severe glaucoma. The trabectome was done alone in 8%, and combined with phaco in 42% patients. And there was significant reduction in the intraocular pressure, which was very statistically significant, from 24.4 to 14.6 at the end of 1 year without phaco, and from 16.6 to 13.4 with phaco. And there was reduction of AGMs by more than 1, and this is the survival analysis plot. So the individuals undergoing trabectome and phaco had 88% survival at the end of 1 year, and with trabectome surgery alone, 67% survival. So just one or two cases, it is very effective in patients with pseudoexfoliation glaucoma and pigmentary glaucoma. So this patient had undergone trabeculectomy in one eye. Pressure was 10 millimeter mercury. The other eye had 24 millimeter mercury pressure. She was on 2 AGMs and with significant cataract. And this is the visual field. And this patient had very good reduction of intraocular pressure at the end of 6 months with no medications. Similarly, in patients who have high risk of hypotony after trabeculectomy, in patients who are young myopes, this procedure is quite beneficial, and this is a young male myope with pigmentary glaucoma. He underwent trabeculectomy in one eye having hypotony, and the other eye I did trabectome, and you can see the cleft, beautiful cleft, and the pressure reduction was remarkable. In congenital glaucoma, this patient, the child who underwent bilateral trap plus trap, one eye was controlled and there was no progression, whereas the other eye, the axial length increased and the bleb got scarred and showed signs of progression. So in this particular patient also, after failed trap plus trap, the angle procedure trabectome was performed, and you can see as you ablate the trabecular meshwork and the inner wall of Schlemm's canal, you can see this outer wall of Schlemm's canal, and this white line can be seen. So this patient did very well. So you need to choose the appropriate candidates, as had already been discussed by Dr. Mahesh, that initially when you start the procedure, the angle should be open, and learning intraoperative gonioscopy with proper visualization of angle and working under high magnification is very, very important. Proper wound construction, avoid limbal vessels while maintaining the chambers, and whenever you are doing any angle procedure, ensure that you are in the right plane along the arc of the Schlemm's canal without any resistance. If you feel any kind of resistance, reposition your probe and do it again, and proper post-operative management. So there is definitely a wider scope for these procedures in the coming days. Thank you very much.
Thank you, Dr. Sunita. While Dr. Siddharth puts up his presentation, we can take few questions. On GAT procedure, KDB, and trabectome.
Congenital glaucoma, there is a trabecular dysgenesis. So, is it that easy to identify trabecular meshwork?
Yeah, actually, it is easy to identify. Generally, what happens is there is high iris insertion. So when you enter with the tip of the trabectome, you just make an incision, and you will get into the right plane. And as you proceed, the iris will fall back. So it is like a goniotomy. In goniotomy also we do the same procedure. Like, we make an incision into the trabecular meshwork, and there is high insertion, as in that patient also the iris was inserted high, and when you make an incision, you can you see the iris falling back as you incise, ablate the trabecular meshwork and inner wall of Schlemm's canal, and you will see the outer wall of Schlemm's canal. So it serves the purpose.
For beginners, ma'am, it will come with practice.
Yes. And you can, now we have bang also, we have not covered. So bang also, you bend the 25 gauge needle, and you can practice with that, because all these devices are expensive. So initially intraoperative gonioscopy, and you just navigate the angle with Sinskey hook just to get a hang of the trabecular meshwork. And then with the 25 gauge needle, you just do a little bit of goniotomy, and it will not cause any harm or bleeding or anything if you just, treat little bit of angle just for practice, maybe after phaco.
Dr. Sunita, where do you source your trabectomes from, and what is the cost for the patient for the surgery?
It is, I think it has not taken off because of the cost, because it has it is the probe cost is 55,000, and it has a machine also. So you have to purchase the machine also, and the company is Amcotech. So
Right. I think what you're saying is, yes, there is a cost involved in these surgeries, but there is a definite space for the MIGS surgeries in India. Though I'm quite sure for all of us sitting here, trabeculectomy still remains the best surgery that we can do with minimal complications. But there is a definite space for MIGS. The advent of MIGS in India has been delayed, but I think we are definitely entering an era where we will be doing a lot more MIGS. So has trabectome become a go-to surgery for you for open angle glaucomas?
Actually, I have been now doing everything, even eye stents, even KDB also. I have. So I don't know whether I will stick to one, and even I'm doing bang also. So we are now more into MIGS, and even we had a session yesterday, wherein even in advanced glaucoma, if you're just planning to do phaco, there's no harm in treating the angle. If it doesn't work that well, at least you will have reduction in the number of medications, and later on you can go ahead with more invasive procedures. At least you can spare the conjunctiva for the time being.
Exactly. So we will definitely be trying trabectome and bang, as you said, and we would request everyone to seriously think about GAT, because the cost associated with GAT, probably the material cost is lesser than what you have for trabeculectomy, and for us at LVP, GAT has become the go-to surgery for open angle glaucomas. Am I right, Mahesh?
Yeah, any kind of open angle, if you like, we surgeons at LVPI jump with joy when we see, at clinic we do the gonioscopy and you see it's wide open angles. Yes. Okay.
So how much is the learning curve, since both of you are doing, for the GAT? Because I feel that you start with the goniotomy, because it is initial. It's a very easy procedure.
Yes,
but
right.
GAT does require some skills, and it has a steep learning curve. So how much and how did you proceed?
It's
Should
steep,
we go ahead,
but
or you want to?
No. I think this is very important to discuss. I have cut short on my presentation, so I'll be quick there.
Like as you said, it's steep, but it is short. It's with a few intraoperative trial procedures when you do, along with cataract extraction. At the end of cataract extraction, like ma'am said, with Sinski hook, you just need to go inside the eye and just practice the movements. And at the end of the surgery, just place the gonio lens and get a visualization of the angle. Then you are pretty sure, like, I can do it like that. And then initial cases, even if it doesn't go full 360 degree, when it passes and when you take it out, even if it has traveled 180 degree also, it boosts up your confidence. I think, with regular practice, it is doable.
I think Mahesh is a very wrong person to talk about learning curve. He really jumped into the sea of GAT and started doing it perfectly right from the word go. I struggled. And I think there are 5 tips that I would give to people from learning from my mistakes. And can't imagine, these are such simple things that you will assume how dumb can this person be to commit these mistakes. But I did it. So the commonest mistake is having the wrong angulation on the microscope. So it is easy to think that you are there right at 35 to 40 degrees, but measure it. You may not be there at 35 to 40 degrees. It happens because if you are at 30 compared to 40, at 40 you have a greater working distance. Your mind will keep telling you, don't go to 40, stay at 30, it is easier to do it. But actually you are increasing your problem by not going to 40. So you have to go to 35 to 40. So measure it, use the Level app. It's very simple to do. The second thing is, and the most important thing, is to get the perfect visualization of the trabecular meshwork. Don't proceed till you see the trabecular meshwork like what you saw in the video. Or the multiple videos of the surgery, you see it well and see at high magnification, 0.9x, and then proceed. So that will make sure that you're going to the trabecular meshwork, not going above to cause a DMD or below to cause an iridodylisis. Though iridodylisis can also bring down the pressure if you cause a cyclodialysis along with it, not in the best possible way. The third mistake is not having the anterior chamber really full during the procedure. Keep an eye on the folds on the cornea and make sure that you are getting a good view, because the viscoelastics, if you don't use the most expensive ones, they will keep coming out. And with just a little bit of manipulation, you may just lose volume and get folds on the cornea, which will prevent visualization. And the third thing is, as already mentioned, get the hand-eye coordination. Again, for someone who starts doing SICS and phaco, it takes time for the hand-eye coordination. Similar when you start doing surgeries under the gonioscope. And the fifth thing is getting used to the pushes or the strokes that you have to make. If you are not positioned well, and instead of sitting with the angle, the site of the goniotomy right there, where you have to do this, it's very painful. We try to sit like little towards the left side, and it makes your job a lot more easier to do the GAT. So these are my 5 top tips for GAT, and I learnt it by doing these dumb mistakes.
I think perfectly summarized, Dr. Siddharth.
Sir, what is little left side? Sir, can you explain that? We are sitting on temporal side. Little
Yeah.
left means
So,
superotemporal. Sorry, superovasal.
so basically, when you sit here, say this is the temporal angle. So you are trying to make your goniotomy or the initial incision through which you will pass the suture right at the nasal point, right? And if you go slightly if you go through the same wound and try to pass the suture, that movement is very painful. Your arm will be dead by the end of doing one GAT. So either use a superotemporal incision to maneuver the suture, or if you're using the same incision, just shift a little to this side and it will be easier, kinder to your arm.
The approach, as much as possible, tangential is better to pass the suture in GAT. So, like as I mentioned in the video also, rather than having the suture in the pupillary axis 180 degree, parallel, if you have it as a tangential, it is easier to pass it along the Schlemm's canal.
And the Grishaber forceps comes in 2 variations. One of them has serrated margins, with which it is easier to hold the sutures, and one of them is plain, through which you will be just gliding on the suture rather than. Also, the suture that you get available, it's not available whole on a very open market. You can order it with individual contact, but you can also make it. You can also make it.
I actually forgot to touch on that. So the usual 5-0-proline with the usual cautery that we use during the SICS, the wet cautery. With that, just keep the video is available.
Okay, yeah. So hopefully I'll show you a good one. This is the unedited video. So this is just a heated iris repositor, and this was the first time we were doing it. So the umbrella tip can easily be made by bringing it close. You don't even need to touch. So this is a good one, where a 5-0-proline suture, you just get it, don't even need to touch. You will get a good umbrella tip. This is heated over a flame, and you get the iris repositor close to it, you will get the umbrella tip over the 5-0-proline.
Now it is available at Orolab also. They are supplying it. I got it from there.
So Orolab comes up with pre-made umbrella tip 5-0-proline, and also when we take a usual 5-0-proline, it's quite long. So Orolab comes with around 40 centimeter one, which is sufficient for the 360-degree movement. I think.
Okay, I think
Siddharth, we can
I have cut down my presentation significantly. I will just touch upon this very important implant, the In Focus, which is now the pressure flow micro shunt. It is not available in India, but still I am discussing it. Why? Because I think, and a lot of people think this is the perfect replacement for trabeculectomy that can happen. Now, why do I say that is something that we will discuss soon. So this implant is made of SIBS. SIBS is a material of which many of the cardiac implants are made, and it is amazingly biocompatible. It's many people believe it's the most biocompatible plastic that that humans have ever made, and it is definitely very small. Now, if you look at the 3-year outcomes, these are amazing outcomes. At 3 years, IOP less than 14, it's happened in 82% of patients without medications. I don't think even when I am a very confident trabeculectomy surgeon, I can say this about my trabs. And all this has happened without any complications related to hypotony, any BREB-related complications. And that is why my firm belief is, even if it doesn't replace trabeculectomy, it is going to be a very, very, very close competitor for trabeculectomy. Now, this is the surgery that we don't do in India. So I just share a video here. This is a video from AIOC2022. You see, this is not a traditional MIGS. So you make a conjunctival opening around 3 millimeter behind the limbus. You use a 24 gauge track and go into the anterior chamber above the iris, into the area of the trabecular meshwork, and then place this implant in. So though you have to open the conjunctiva, this is a very brief procedure, and this implant lies there in the subconjunctival space, gives you very diffuse blebs. So I must acknowledge AIOC2022 because he's a person who makes very, very nice glaucoma implant related and phaco videos, and it's a favorite of mine. After, of course, T-Series and PewDiePie. No, I'm joking, I don't really. So I'll just briefly again mention about Zen implant. It's a similar procedure, and what happens in this procedure is it's a collagen implant made of pocrine collagen, and it is the reverse direction in which the in-focus implant was placed. It's placed from ab interno approach, and this is what the implant looks like. And a lot of people actually inject subconjunctival mitomycin before injecting the implant. And once you locate the trabecular meshwork, you can just inject the implant from the trabecular meshwork to the subconjunctival space. It is important to take the needle through the tenon. So unlike trabeculectomy, which is a subtenon thing, unlike in focus, which again is a subtenon thing, this implant has to be above the tenons and below the conjunctiva, so that you get a bleb in that area. The problem with both these implants is a frequent and repeated need for needling. So because these implants, the ends of these implants are very small, even if a small fibrous plug comes in there, you will need to go do a small needling. So that is the challenge because of which there are still some reservations about the implants, and I think all of us are very eager to see these coming to us and reduce the surgical times. Now, unlike these two implants, there is an implant that is, or a MIGS option that is available. So it's the Taj Samudra of all the implants, the iStent. Now, iStent has a time-proven record in many countries in the West, and it's a very, very small implant, the length of which is 1 millimeter. So this is 1 millimeter long, and the part that remains in the anterior chamber is 1/4 of that, the snorkel that you see, that helps drain the aqueous. Now, this is a table, a long one, but I want you to focus on only two aspects. So if you see a single iStent, it will reduce the intraocular pressure to somewhere the range of 8.6 to 27.3 millimeters. Now, what is visible along with these numbers is the large standard deviation, which basically means that there is a significant amount of variation in which these iStents will bring down the IOP by. When one doesn't work, you implant another. So 2 iStents can bring down the pressure by 27 to 36%. Okay. Now, very interesting trial by Katz et al. They tried, they made 2 groups of consecutive POAG patients, put 1 implant in one group, 2 implants in the other group, and 3 implants in the other group. So they have a very homogeneous population. This is the only non-randomized controlled trial which I would recommend to understand. So one eye stent, intraocular pressure level 17.4, two eye stents 15.8, and three eye stents 14.2. So this is the usual range in which trabeculectomy does. So three eye stents is equal to trabeculectomy, but each eye stent is going to cost somewhere between 1.3 to 1.5 for the patient. So when the Ambanis come, you can offer three eye stents to them. Once again, this is just a joke. These implants do have a place in our practice. Otherwise, we will not be talking about. The safety of each and every MIGS procedure that we have spoken about is amazing. So let us look at the procedure. I will skip the gonioscopy adjustment part and just go to the. This is the only situation when you probably pray for a bleed in the angle where you can visualize it. So you go almost parallel to the trabecular meshwork, go at around 10 to 15 degrees, place the implant there, and then withdraw the injector and just push the implant once more, the eye stent, into the trabecular meshwork vertically and horizontally to make sure that it stays in place. This is typically performed along with phacoemulsification after the surgery is over. So it gives you a very good access to the trabecular meshwork and reduces the problems that you could have with the bleed affecting the trabeculectomy, the phacoemulsification later. There is a cousin of eye stent, the eye stent inject, which implants two of these modern design or a newer design eye stents into the trabecular meshwork. It costs a little more, but probably will also work a little better than the eye stent traditional one. We have already reached a stage when eye stent is being called traditional. Thank you. We'll be happy to take any more questions in say 2 minutes before we are made to leave this hall.
Yeah, eye stent is available. We have all done. He is sitting there. From Glaucos, he is there. So I think you can.
Just to one point, I think I liked your last line that it is costly, of course, than GAT and the bank, but it's not 1.5, it's 0.5 actually. So 42,000 plus taxes is the cost for one eye stent in India, and for eye stent inject, the cousin brother, which is having two stents, is actually costing 1,05,000 rupees to the patient or to the institute also. I think
Yeah.
Madam has actually given us a better solution because it has a bigger MRP, so which many people can use it for their own margin development. But Sunita Madam is the first person who said that let's not charge it more, let's charge it to the patient, the device, and of course the procedure.
See, for the initial few surgeries, when surgeon is also learning, because I think every procedure has a learning curve, so you can just charge the patient the cost, and but it is combined with phaco. So overall, it will. I'll prefer eye stent inject because the pressure lowering is much better than the single eye stent.
And also, I think the technique is easier.
Technique is also very easy. But see, since the device is expensive, so initially you are, scared because it is an expensive device that it should go at the right place and it should be properly placed in the trabecular meshwork and in a wall of Schlemm's canal. So that scare is there, but once you do two eye stent, then you feel very confident. So the learning curve is very short. But before that, I always tell, that you have to first practice goniotomy. Because without practicing goniotomy, just by bang also you can practice and have a hang of the angle. I think that is very, very important. And goniotomy, you can do what problem I faced in eye stent. He also knows that goniotomy I could do in, less magnification, because our microscope, we do not have Lumera. We have Lumera eye. We do not have Lumera, what is that? 700. Lumera 700. So I think that was a problem, because when you increase the magnification, the illumination goes down. So you have to really get used to it. So initially practice few goniotomies and then go to eye stent. So
What problem is used by you? I know all three of them actually, and
yeah.
two of them I've seen. I think that what problem is
मैंने ये कॉपी
Mahesh.
ये वाला है ना नहीं
Yeah.
खुलेगा इसके साथ ही सर वो सिर्फ वीडियो
So we have the tendency when you put it, you just want to leave it, release it. So you can't release it. If you release it, you're pulling it back. So you have to come out first and then leave that trigger. So I think that is the crux. So you need some, mental peace while you're doing these procedures. You have to be calm. Otherwise, but it's very much possible.
ठीक है सर
I think the basis for everything is a good gonioscopy, a good visualization of the angle, and before doing the actual procedure or going for the actual MIGS procedure, good practice sessions with Sinsky hook or with a 26 gauge needle to practice the movement of any of the instrument that you're going to do. Because it's all based on the Schlemm's canal angle-based surgeries. The movement of the hand is more important than which device are you going to use.
So all these devices are covered under insurance also. So if you have, if your patient is insured, you can get it. So there's no problem.
सॉरी
No, surgery, complete surgery. You can send them.
So actually we have got a reimbursement of almost around 2 lakhs for the procedure with both IC inject, which is almost around 1,56,000 as the MRP price, along with procedure charges, and you also have to use a gonio prism, which is also costing something. So you can get reimbursed even for that. We have got it. Not we can get.
भाई ऐसे मत
We have got it at least 5 to 10 cases we have got it.
So now the next patient that I am going to is reimbursed.
In fact, your first
Initial.
patient also got reimbursed with some issue, but
Yeah.
the second patient has already got approval.
So
So we should use this as a promotional thing for the instruction course.
That it is can be reimbursed.
This much can be reimbursed.
I think we have overshot the time. Yeah. Thank you again for patient listening.
And Saikat, sorry for the misinformation on the price.